In the interest of time, I'm going to go ahead and get us started. I know some folks are still joining. That's great. Welcome, everyone. Good morning. My name is Kim Porter. I'm the executive director and co-founder of Be a Part of the Conversation. Also from our organization is Bob Lamb, our director of operations and programs. I really want to welcome you to this. This is our first time hosting a continuing medical education program, but we have some folks with us who have been doing this for some time, and we're really glad that they're here. Tell you more about them in a moment. I first want to thank our community partner, the Montgomery County Office of Drug and Alcohol. We are coming up at the very end of our 5-year grant that we had to talk about the Youth Marijuana Prevention Project. And we have much, much more to talk about. So I know this isn't the end of this conversation, but we're very grateful to Montgomery County for all the support and for encouraging us to have this program for all of you today. I really want to express sincere gratitude to the Caron Treatment Center. One of our presenters today, Dr. Mohammad Sarhan, is with Caron. We would not be able to present this CME program without their incredible help, especially Jess Ayer. I'll tell you a little bit. Jess was not able to be with us this morning, so she sent me a little info to give you about Caron. Caron Treatment Centers is an internationally recognized nonprofit dedicated to transforming lives through addiction and behavioral healthcare treatment, research, prevention, and addiction medicine education. Caron also provides concierge signature treatment for executives, healthcare professionals, and older adults, and offers neurorestorative healthcare at their Keel Medical Center in Palm Beach County, Florida. In addition to their Pennsylvania and Florida campuses, Caron provides services in Wyomissing, Pennsylvania, Philadelphia, Washington, D.C., Atlanta, and New York City. Caron accepts several major insurance plans and provides financial assistance for those who qualify. For more information, please visit caron.org or Caron Treatment. So we are recording this program. We will not publish it when we get to the Q&A. If anybody asks any personal questions that really should not be included in the final product that will be on our YouTube channel, I promise that we will edit out anything personal or private. I'm going to ask Bob Lamb to now explain a little bit about the CMEs that you're eligible for today.
Yeah, so to obtain your certificate for attending this course, this is eligible for 2 hours of the AMA credits. A link when this meeting is ended or when you leave the meeting, a window will pop up through Zoom that will take you to a link to an evaluation form through our SurveyMonkey. So you'll have to complete that. We'll also post a link in the chat, and the link will temporarily be on the follow-up page that Kim is about to share. But you'll complete that evaluation. Make sure you put your emails in there correctly so that we don't get any bounce backs for sending out the certificates, and we'll generate and send the certificates within 7 to 10 days for you all to receive. So if you have any questions, feel free to reach out to me, or if you have anything that comes up during the chat or any issues, we'll stay on a couple minutes as the program's ending to make sure you can access the evaluation appropriately. But yeah, that's what you got to do.
Great. Thanks, Bob. We will allow questions after each of the presenters share their slide decks. But then once this is recorded, it takes a little time to process, but then we will post it on our YouTube channel. But you'll also find a lot of other resources on our website, including, as Bob said, that button for the evaluation that'll be there temporarily and on our website. And Bob's going to share these links in the chat. Conversation.zone/CE is where we have all of our continuing education programs posted. So you can find, and then if our presenters today are sharing any resources that we want to make sure you have access to, including, by the way, their slide decks, they've very graciously agreed to share their slide decks. So all of that can be found on this follow-up page. You can find a lot of other information on our YouTube channel. We have more than 150 programs recorded and posted there. We talk about all sorts of things year-round, all related to substance use and related behavioral health challenges. I also just want to let you know that we have a lot of family members that we work with, and we have 21 parent partnership meetings that take place every week. Some of them take place virtually, some take place in person. So if you're all over the country, it doesn't matter. We've got about 11 or 12 Zoom meetings that are happening. Those are on this calendar in green. You just click on those, get the link. If you're local, you can find these local meetings that are in purple, has the details about the location. These are for family members like myself who have a loved one who has at some point in their life struggled with substance use. And we find so much support from one another. We also, in the same vein, we have this family recovery course. This is a deep dive for family members who are truly in the soup. They are dealing with their loved one. This is the parental guardian role. The loved one can be of any age, though. It could be a teenager. It could be someone well into their adult years who is struggling or has struggled with substance use. All of this is completely free to attend. I hope that you'll consider checking out either the parent partnership meetings or the family recovery course, or sharing this information with folks with whom you work. So on to, wow, we have some great presenters today. I'm so excited. I'm going to read the bio for Dr. Stuyt right now, and then I will tell you more about Dr. Sarhan when he's ready to present. Dr. Elizabeth, or Libby Stuyt, is a board certified addiction psychiatrist and has worked in the addiction behavioral health field since 1990. She was the medical director for the Circle program, a 90-day inpatient treatment program funded by the state of Colorado for persons with co-occurring mental illness and substance abuse who have failed other levels of treatment from 1999 to 2020. She was instrumental in helping the Circle program to become tobacco-free in January of 2000, and has been a strong advocate for the need to address all addictions at the same time, including tobacco, to improve outcomes. Dr. Stuyt has been actively incorporated complementary treatments into treatment programs, including the 5-point ear acupuncture, NADA protocol, and BST, that's brain synchronization therapy, to help patients recover from addiction, as well as trauma, which often underlies addiction and chronic pain issues. She's on the board of the International Academy on the Science and Impacts of Cannabis, otherwise known as IASIC, and believes that people should be following the science regarding policies relating to cannabis. Again, I'll tell you more about Dr. Sarhan a little bit later. Thank you so much for being here, Dr. Stuyt.
Thank you, Kim. I really appreciate being here and being able to share this information with people. So let me get my slides to work. This is my disclosure slides. I don't have any relationship financially. I am on these two organizations, and I encourage people to look at these websites if you're interested in more of the science behind all this. We have lots of information. These are the things that I'm hoping to cover. It's a lot to cover, and I'm going to try and do it as quickly as possible. I just wanted to start by saying why I got into this in the first place. And as Kim said, I was fortunate to run this program, that pretty phenomenal program, really doesn't exist anywhere else in the country, because it's a 90-day inpatient treatment program funded by the state of Colorado. And it was for people who have failed everything else. So it took people who had been in multiple treatment programs. And for 10 years before we basically legalized marijuana in Colorado, we had successful completion rates of the program of 80%. So 80% of the people that went through the program completed the 90-day program and went on to do well in the community. When we opened the doors for recreational marijuana in Colorado in 2014, I started seeing problems that I really did not anticipate. And I started telling people about it, and people would say, oh, no, that's just cannabis. That can't be anything. That's not a problem. But I saw less and less ability to function in this very high cognitive behavioral program because of the impacts. The other problem was we got a law in Colorado in 2015 that allowed people on probation to use medical marijuana if a doctor recommended it. And that, to me, is pretty insane, because the doctors weren't really talking about helping people with cannabis. They were just giving them a card, and then they would go to the dispensary and get these high potency THC products. So I started seeing people where cannabis use disorder was their primary problem. I had never seen that before. And I started seeing some of the worst psychosis I had ever seen, worse than methamphetamine, and all these other things that made me start looking into the literature. So I actually have done a lot of literature search to try and compare to my anecdotal experiences. So to me, the biggest problem has been this massive increase in the potency of THC. We legalized medical in 2000 in Colorado, and before that, up to that point, the highest THC potency was 5%, and we had no concentrates. Now we have these concentrates that people are using with smoking with blowtorches. So cannabis has been around for centuries, and all the way up to the 1980s, the THC potency was always less than 2 to 3% in the plant. Then it got up to 5% in the 2000s. Then the concentrates hit the market in Colorado in 2010, and then the potency just kind of took off. So now we have an average of 20% in the plant, and we have a 69, 70% average in the concentrates, and it goes 100% pure. And there is actually no research at all on any of these high potency products that say they're safe or effective for any medical condition. But we have multiple studies showing that there are significant problems with them. So the first thing here is this Whiting article. If you recall, in 2017, the National Academies of Science came out with publications saying that some things that cannabis could be helpful for medically. And this is the meta-analysis systematic review of most of those studies that were done to that date. And if you look at that, the highest level of smoked cannabis was less than 10% THC. And most of those studies were done with the isolated cannabinoids. So there basically really is no legitimate science that validates medical cannabis greater than 10% THC. In fact, there was this one study where they were looking at healthy individuals who were willing to have their forearm injected with capsaicin, which is apparently very painful. That's the stuff out of hot peppers. And they found that 2% THC cigarette provided no benefit. 4% actually had significant pain decrease, but 8% caused increased pain or hyperalgesia, which is something that we see with opiates as well. This is a researcher I respect. He is an anesthesiologist. He's a pain management researcher, and he studies cannabis for pain. And even he says that the THC range supported by scientific evidence for medicinal purposes is lower than 10%. When you start getting into higher than 10%, you start getting into very risky areas. And his group went around the country looking at the different states that had legalized, looking at different dispensaries. This is Colorado data. And pretty much everything that's available in both the medical and the recreational market is greater than 15% THC. And much of it is the concentrates that are much higher. That has led us to having products like this that are available in the medical market with no research behind them. But because the industry has been allowed to heavily advertise and market these as medicine, people think they're safe. And so we have kids using vaping products, dabbing, edibles that are very high potent. And if you actually look at what we have available, we do have FDA approved cannabinoid products. And so there are things like dronabinol or Marinol. We do not have Sativex or Nabiximols available in this country yet. It hasn't gone through FDA approval, but it's available pretty much everywhere else in the world. And most of the studies have been done with that, which is this balanced dosing of 2.7 milligrams of THC, 2.5 milligrams of CBD. And so the recommended doses for these FDA-approved drugs are much, much lower than what people are using in what's available in the medical market. And we had to actually pass a bill that I'll talk about later in Colorado to actually put some controls on the concentrates. But we put together this little video that you could click on if you get these slides, and you can listen to the video talking about how crazy this is. to me, the best thing that has come out of all of the cannabis research has been a better understanding of the endocannabinoid system. And this is really a phenomenal system that we have naturally in our brain that we really didn't know about until the 1990s. And this is a very important system that during puberty helps the brain decide what are we keeping and what are we getting rid of during normal brain development. Yasmin Hurd is a phenomenal researcher in New York who has been researching the transgenerational effects of cannabis exposure during all the levels of development, starting in utero and throughout development. And this is a webinar that she did back in 2022 that I really encourage people to listen to because it's pretty fascinating. And what I got out of this webinar is no one should be using cannabis unless you're 25 years of age or older and you never plan to have children, because it actually can affect the gametes, the egg and the sperm, which then can affect the developing brain of the offspring. So this is kind of what happens. You know, you're born with a certain number of neurons and they dramatically increase during childhood. You have increased dendritic action because a lot of things happening in the developing brain during that time. And then in puberty is the brain is charged with deciding, well, which neurons are we going to strengthen by myelinating and which neurons are we going to prune because they're causing interference. And it's actually two receptors in the brain that are responsible for this. One is the nicotinic cholinergic receptor, and that's called nicotinic, not because we're supposed to smoke tobacco, just because nicotine works on that receptor. And then the CB1 receptors, called cannabinoids, not because we're supposed to smoke cannabis, but cannabis does work on those receptors. And so those are the two receptors responsible for this, which to me means the worst drugs that a teenager can be using are tobacco and marijuana. But that's mostly what teenagers are using. And one of the problems is the binding capacity of delta 9 THC is much stronger than the binding capacity of our own natural endocannabinoid named anandamide. And these levels are typically elevated in the prefrontal motor cortex during late adolescence, but they are reduced if somebody is using high THC. And so this can really disrupt this very delicate process, which then results in kids having problems with impulse controls and cognitive and executive functioning problems. So this is just a study showing that if kids are using cannabis, if they're more likely to use the higher potency products, then they're much more likely to develop problems with psychotic symptoms, depression, anxiety, and also cannabis dependence. And again, I am sharing all these slides with you, and so the resources are on the slides, and I encourage you, if you have more interest, to look into these studies. This is an interesting study because it's basically showing that cannabis may be worse than alcohol for the developing brain. And this is looking at multiple cognitive effects. And the blue line are kids that are not used cannabis at all. And this is during their different school grades from 7 to 10. And then the red line is kids that are using concurrently and have used in the past year. And so we have problems with errors on working memory. The kids using marijuana have much more problems than the kids that are not. And this is perceptual reasoning task. Those kids not using marijuana are much better at this. And delayed recall memory tasks, kids not using cannabis are better. And then, of course, the number of errors on inhibitory control tasks. So this is basically the frontal lobe. Kids that are not using cannabis have much less errors than the kids who are using it. And this really does affect intelligence quotients. So this is a prospective study following multiple children who were exposed to cannabis in utero compared to kids that were not exposed. And so the women were interviewed about their use of cannabis. And then when the kids were 6 years old, they were tested for IQ, and the examiners were blinded, so they did not know who had been exposed or not. And they found that those kids that were exposed in utero had a significantly lower IQ than the kids that were not exposed to cannabis. And of course, right now we have a significant increase in this country in pregnant women using marijuana to help with nausea of pregnancy or anxiety related to their pregnancy. And it may help them, but they're not thinking about the effect on their offspring. This is a very large prospective study in New Zealand following people who started at the age of 13. So this is before they started using any drugs. They got their IQ done at 13, and then they repeated it at 38. And they found that the people who never used marijuana had a pretty stable IQ over that period of time. Those who were used regularly had a decrease in almost 8 points in their IQ. This group has continued to follow these people, and so this is a more recent publication looking at these people at the age of 45. And I've highlighted in yellow the important things here, that long-term cannabis use decreased their IQ by an average of 5.5 points, whereas non-users had no decrease. And then compared to tobacco, alcohol, and then people who were used cannabis but then stopped or weren't using very often. And still, cannabis has the biggest effect on IQ, even more so than long-term alcohol use, which I think is very interesting. Because this is how these things happen. So in our brain, the hippocampus is a very important place where we put all of our new memory and learning. And it is also part of the brain that has new cells being born all the time. So there is neurogenesis in the hippocampus on a regular basis, except if you're using any addictive drug chronically. And this has been shown to be for all addictive drugs, that you decrease neurogenesis and can shrink the hippocampus. And that makes it difficult to learn new things. This is why I've always advocated that treatment should include tobacco. So people should quit using tobacco if they want to have the best outcomes, because it can actually cause people to have difficulty learning new things. And this is studied in animals. This is a really cool test to study whether an animal can learn. And so there's basically this big vat of water in the middle of the room, and somewhere under the surface is a little block of wood. And you put the animal in and have it swim around, and you calculate how long does it take before it bumps into that block of wood, and it can get on it and say, oh, good, now I'm not going to drown. And you know this animal can learn because you put pictures all around the room, and that animal, when it's sitting on that block of wood, can triangulate where it is in the vat, so that the next time you put it in there, it goes right to the block of wood. And that is a very smart animal. Well, what they've done is they've done this with all drugs, including THC and including nicotine, where they drug the animal up, and the animal cannot find the block of wood to save its life. And that's mainly because it has to swim around until it bumps into it. And that's because it cannot learn something new, because the hippocampus has been shrunk, and it makes it difficult to learn anything new. Now, the good thing is recovery is completely possible, I believe, because what they found is they take the drugs away, they put the animals in Rat Park where they have their friends and good food, and they have these wheels where they can run to their heart's content. And they, within a short period of time, can find that block of wood so they can learn. And this is really important information, because one of the things that we have discovered is one of the best things to improve neurogenesis in the hippocampus is voluntary exercise. And so that's, to me, why all treatment programs should have exercise every single day. But if you're using marijuana, especially the high potency marijuana, you definitely lose gray matter in your hippocampus. So it decreases neurogenesis. And it puts people at increased risk for early psychosis, and which can also lead to false memories. And this is something I was seeing a lot in my treatment program, people with very fixed delusions. I mean, when somebody has a delusion or they are diagnosed with delusional disorder, that is almost impossible to treat. You cannot get rid of delusions. And these are basically false memories, false understanding about what has happened to you. And on the opposite, our endocannabinoid system is supposed to help us with our memory. So one of the problems that I think leads to increased addiction is the increased potency of a drug. And we've known this forever about most of the drugs. We definitely see this with the opiate epidemic, that codeine is a lot less addicting than OxyContin. And now we have fentanyl, which is extremely potent and a lot more addicting. We are now seeing the same thing for cannabis. Back in the early 90s, when I first got into this field, we did not believe cannabis was physiologically addicting. We just thought it was psychologically addicting, but it wasn't a big deal. Now, with the high potency, we absolutely see that this is very addicting. The Dutch figured this out. They found that when their potency in their plant reached the average of 20%, which is what we have now, there was a lag time, but there was this increased need for admissions for treatment for cannabis use disorder. And they actually came out in 2016 recommending that anything higher than 15% should be considered a hard drug like cocaine. And they recommended capping the potency. This is data from the United States. These are survey data where they survey thousands of people in the country. And back in 2004, 2005, that basically showed that most people do believe nicotine is the most addictive drug we have. It's the hardest drug for people to quit. Alcohol, the number one drug people use, is less problematic in that regard, but most studies say between 15 to 23% of people who use alcohol actually become dependent on it. This back here was cannabis when it was less than 5%. And it wasn't considered that addicting. However, in this survey, 2012, 2013, and we got the concentrates to hit the market in 2010, this has increased to 30%. And I guarantee you it is even more now. Most of the research is showing that people that start using marijuana before the age of 18 are 4 to 7 times more likely to develop basically marijuana use disorder when they're adults. And I am seeing it so comparable to nicotine now, because I have always had treatment programs that are tobacco free, and people say nicotine is the hardest drug to quit. Now I am seeing that the high potency THC is just as hard to quit. And so we see a true withdrawal syndrome. This is physiological addiction, and these are the symptoms of it. There's a lot of irritability, anger, anxiety, all the things that are exactly opposite of what marijuana is supposed to do for you. Like, you can't sleep, you can't eat. And this can last for some time. And I see this happening almost immediately. When people get into treatment and they have to stop and they can't use, but then it can last for some time because it's fat soluble and it can sit in the body for a long time. And so there are many studies now showing that people that use medical cannabis actually are developing cannabis use disorder. Now, they initially don't think they have cannabis use disorder, but if you think about it, when you're taking a medicine for something chronic, you usually take it every day and sometimes take it all day long. And that is exactly what's happening with people using medical cannabis. And if they're using it appropriately with a well instructed physician who knows a lot about this, and they're using low potency THC, balanced CBD, we are not seeing this addiction problem. But most of the people are not doing that. They're just going to the dispensary and they're getting whatever the bud tender recommends. And it's usually high potency products. And so this study is showing that basically everybody is experiencing some level of withdrawal, and 25% of these people had severe symptom withdrawal. Most of the withdrawal is associated with people smoking cannabis, longer history of use, and greater frequency of use. This is another interesting study with medical cannabis where they actually had two groups of people. One group, they gave the card and said you could use it right away. And the other group had to wait 12 weeks before they could use the card. And then they followed them to see if they developed symptoms for cannabis use disorder. And they found that 17% of the people where they could use the card immediately developed cannabis use disorder in 12 weeks. That's crazy in the fact that, it takes years to develop dependence on alcohol. You have to really work at it, but you can develop a cannabis addiction problem very, very quickly. And so what this study was showing, the people most likely to develop cannabis use disorder were the ones that were using it for depression or anxiety. So this is a much more recent review. This is published this year, and basically showing that people who are using medical cannabis, 1 in 4 are developing cannabis use disorder. And so they basically say we definitely need to be researching this more because this is problematic. And then if you go back to the adolescents, there is data showing that of the kids who are 12 to 17 who are using marijuana, 44% of them have cannabis use disorder. That is scary. And then I just recently heard this. One adolescent substance abuse treatment center in Denver, Colorado, reports that 97% of the adolescents there are there for the treatment of cannabis use disorder. Then we get into the problem with psychosis. This is like the first study that came out showing that high potency cannabis really increases the risk. This is looking at people 18 to 65. So these are people, throughout most of life with their first episode psychosis. And what they found was that people who were using the high potency product they called skunk, which is higher than 15%, had a 3 times increased risk of psychosis. If they were using this daily, there was a 5 times increased risk of psychosis. But if they were using the old time stuff that was less than 5%, there was no associated risk for psychosis. And I think this is why we haven't seen this until now, because we had the old time stuff. And so this study was replicated in multiple sites in Europe and one site in Brazil, and they found the exact same thing, except this now was for 10% or more. And so that seems to be the cutoff, that less than 10%, there might be some benefit, depends on the situation. And more than 10%, you're really starting to look at potential problems. And this is a big population-based study out of Denmark, where they basically were saying, well, if increased potency does increase risk of psychosis, we should be seeing this, because in Denmark, over time, they have had increase in the potency of THC. In fact, I've heard that Denmark has the highest amount of THC in their marijuana in Europe. So this is looking at over 7 million individuals over a period of time. And they found exactly that over this period of time, they have had a 4-fold increase in both cannabis use disorder diagnoses and schizophrenia. Now, all drugs of abuse have the potential to cause psychosis, and we know that well from methamphetamine, cocaine, alcohol. However, this study was looking at, well, once you have a drug-induced psychosis, what is the likelihood that you're going to convert into either schizophrenia or bipolar disorder diagnosis? And they found that the highest conversion rate, almost 50%, was for cannabis-induced psychosis. So this is basically worse than things like methamphetamine. And then this is very new. This is just published, Canadian data, showing that when kids are using, they are increased risk for psychosis. So this was showing that kids using cannabis, so these are, young people, 12 to 19, they have an over 11 times greater risk of developing a psychotic disorder than if people started later. So basically, older people didn't have that risk. And they felt that this was possibly due to the rise, because this is stronger association than has been previously published. And they believe this is because this is more recent data reflecting the rise in cannabis potency. Then we get to the suicidal correlation. There's more and more research demonstrating that there is a strong correlation with suicide and cannabis use. This is a systematic review and meta-analysis of over 11 studies, 23,000 adolescents, showing a significant increased odds ratio of both depression, suicidal ideation, and suicide attempts. This is significantly greater in cannabis users than non-users. In Colorado, THC is the #1 drug found present in teens who die by suicide. And we do have a very high suicide rate in Colorado. This is CDPHE data just showing that once we opened the doors for recreational marijuana in 2014, there has been a significant increase in the number of teens dying by suicide. And marijuana is the #1 drug present in toxicology. This is a national survey data. And so again, this is up to 2019, looking at kids 12 to 17. And they found that past year marijuana use was a significant risk factor for suicide. And this study found no gender differences and no racial differences or ethnicity. So this does affect everybody. This is a more recent study actually looking at whether the states have legalized recreational or medical, and finding that, of course, if there's no medical, no recreational, they have less risk for suicide deaths. And on the left-hand side are the females, on the right-hand side are the males, and the males have a much higher significant rate. And this red line is the recreational states. So the states that have legalized recreational compared to medical versus the states that have not. And so this is more and more correlation data, but I think it's very important. And then if you think about the pandemic time, we definitely have information that the pandemic made mental health in youth much worse, and many other ages too, but we've seen a lot of problems with youth because of the pandemic. And so this is a study, basically this is CDC data in their morbidity and mortality weekly report, looking at people 10 to 19, and these are the reported suicides. Now, this is not reporting cannabis at all. This is just looking at people who were reported to the National Poison Control Center doing overdose attempts. And the overdose was mostly stuff available in most households, like Tylenol, Motrin, and different antidepressants and Benadryl. And very scary. Kids 10 to 12, there was a 73% increase in attempted self-poisoning. Adolescents 13 to 15, there was almost a 50% increase. And so this is not talking about cannabis. However, there's a corollary article, a study. This is one looking at cannabis reports to poison control centers during the same period. So this is looking at, well, this is over a much longer period, but it is definitely looking at the pandemic era. And as you can see, there was a significant dramatic increase in the reports of cannabis in suspected suicides. And so neither one is definitively showing causation. However, if you put these two articles together, it's a very compelling argument that cannabis use does contribute to suicide. And as you probably recall, definitely in Colorado, it was that Colorado made cannabis dispensaries essential businesses during the pandemic. So people could absolutely get their cannabis. The suicide is not restricted to adolescents. It's also found in adults, and this is data out of veterans, just showing veterans with cannabis use disorder have much higher rates of suicidal ideation and suicide attempts compared to those not using cannabis. And this study did a really good job of controlling for pretty much everything that contributes to suicide. Marijuana is not the answer for post-traumatic stress disorder, in spite of the fact that multiple states have an indication for medical marijuana. There has yet to be a single well-designed study demonstrating benefit. Most of the studies have demonstrated harm, and that was like the very first one that came out in 2015, showing that these are veterans that have been in PTSD treatment programs around the country. They're about a month long, and then following them for 4 months after the treatment. And they found that the people who had quit using marijuana or had never used marijuana actually had pretty good outcomes. But the people who started using marijuana after that treatment had the highest level of violent behavior and PTSD symptoms. Why this is not the answer is even though it works, it seems to work, it's temporary. It gives temporary relief. So it does disconnect people from the traumatic memory, very similar to what benzos do, very similar to what alcohol does. However, in order to keep the symptoms at bay, you have to use every day, sometimes all day long, which then sets you up for the problems with cognitive impairment, psychosis, worsening psychosis, because PTSD can cause psychosis. And this addiction potential, it becomes a very vicious cycle. And then this problem of creating false memories. This was a study that was highly anticipated, was going to prove that cannabis treated PTSD. It was a well-designed study. They had multiple levels. They had high THC, low THC, balanced THC, CBD, and that there was no difference between any of the preparations and placebo. So there was no benefit. This is an interesting study out of Canada where people can get an app on their phone where they self-diagnose PTSD. They put in their symptoms, then they put in the product they're purchasing and whether using, and then whether it helps their symptoms or not. And so they can follow this because they have over 3,000 cannabis products that are covered by the government. And they found that, yes, initially, acute cannabis intoxication did provide temporary relief from intrusions, flashbacks, irritability, and anxiety. However, the baseline PTSD symptom ratings did not change over time. And if you do any work with trauma, like you're doing EMDR or something, you actually want the ratings to go to zero. However, that didn't change. And then they found that people were having to take higher and higher doses, meaning they were developing tolerance, which means they were developing withdrawal symptoms. And so basically, this study was showing that this is not an effective treatment. And then these are coming out of the Veterans Administration, just showing that veterans who used cannabis were much more likely to have co-occurring major depression, generalized anxiety disorder, suicidal ideation, and problems with cognition compared to those not using cannabis. So they said it makes people worse. And then this is very recent. These are the Department of Veterans Affairs and DOD releasing their recommendations for the use of whatever in treating post-traumatic stress disorder. And they recommend against using benzodiazepines, cannabis, or cannabis-derived products. Then another big problem is the drug-drug interactions with cannabis. This is something that I think prescribers, physicians need to learn more about. We're seeing a lot of problems, especially with it, and I've seen it a lot with youth who are having to have surgery because I've even heard of orthopedists refusing to do elective surgery until they stop using cannabis because it can cause problems with anesthesia. People are requiring higher doses of anesthesia. It's very difficult to control pain. And a lot of this is because of interactions. Also with people that are on things like blood thinners, this can be a real problem. And I was also seeing it with people that were using antidepressants, and saying that their antidepressants were not working. And I was find out they're using high potency THC, and I would have to explain to them that, well, this is probably why your antidepressant is not working. And then we have the problem with violence. And this is something that has been around for a long time, but we're seeing much, much more of it. This is an old time study. So this is done back in the 90s. So this is when we had lower potency THC, but this is with psychiatric patients. And so these are people that were stabilized in a hospital and then followed after discharge, and they were followed to see what substances they were using and how it correlated with violence. And they found that cannabis use was the one with subsequent violence, significantly more so than alcohol or cocaine. This is more recent, looking at the same population. So these are psychiatric patients with psychosis. They're stabilized, and then they're followed. And they found that the ones, cannabis use disorder was the strongest risk factor for violent behavior. Then this is the Katie study that was really done to help determine what were the best antipsychotics for people with schizophrenia. But they actually had a violence indicator that they were following. And they found that persistent cannabis use predicted subsequent violence. The violence did not predict cannabis use. So it wasn't like these people were self-medicating. It was more that this was a unidirectional relationship, and it persisted when they controlled for stimulants like methamphetamine and cocaine and alcohol. So they do say that cannabis should be an important risk factor for violence when you're working with people with schizophrenia. People with schizophrenia are not inherently violent, but apparently when they're using substances, that can increase that possibility. This is a very large systematic review or meta-analysis of multiple studies on youth, just looking at whether violence and cannabis are associated. And they definitely found that cannabis use in this population is a risk factor for violence. And then this is veterans, showing that the gray bar are people with current cannabis use disorder. The orange bar is they've had a lifetime history of cannabis use disorder, but not using currently. And the blue bar is no lifetime history of cannabis use disorder. And they're just showing that when you're acutely using cannabis now, you have much more difficulty managing anger, aggressive impulses and urges, and problems controlling violence in the past 30 days. Dr. Miller and his group have done several publications on this, looking at these high-profile cases that are in the news, and showing that, so these are very violent people that have had symptoms of psychosis and were using marijuana. And I'm sure you recognize many of the names in here, the Boston Marathon bomber, the Robert Deere was the Planned Parenthood shooter. So that's something to take into account. This was a more recent case that was done in California. This actually happened back in 2019, but it only recently went to court. And this was a woman who was not a regular marijuana user. She was high functioning, and her boyfriend and she actually shared a bong, and she went completely psychotic and started stabbing him. He stabbed him over 108 times and killed him, and then stabbed the dog, and then was stabbing herself. And she had to be tased in order to drop the knife, so she stopped stabbing herself. She had by the psychologist who interviewed her, cannabis-induced psychosis, and she's no longer has that. So she's recovered from that. And so when it went to court, she actually, that was her defense, and she was sentenced to 2 years of probation with no prison time. She actually is now speaking publicly. I think that's part of her probation, to share her story with people. This is a gentleman that I contacted in Colorado because he contacted me. I had put out a message to some of the domestic violence treatment providers to see if anybody would be willing to talk to me publicly. And he did. And very nice gentleman. Sad case in the fact that he was not a regular marijuana user. He had only used it maybe one time in his adolescence, and now he's a veteran. He did not even realize he had post-traumatic stress disorder until this episode happened. But his girlfriend bought some weed and they used it together. And he said he didn't feel really bad until all of a sudden he got really psychotic. And he got his gun out, and apparently his dogs were fighting, and so he was trying to stop the dogs fighting, and then he shot them and his girlfriend, and luckily she survived, and she has become his strongest advocate. He says that the reason he is speaking out is he's so concerned about his peers, his fellow veterans who are using marijuana for post-traumatic stress disorder and not realizing that these kind of things can happen to him. And he's now in treatment for post-traumatic stress disorder. This is information that Texas collects. We don't collect this in Colorado that I have been able to find out. I definitely encourage you to be collecting this in Pennsylvania. This is looking at childhood deaths in neglect and abuse situations, and finding that the number one drug done by perpetrators is marijuana. This is also out of Arizona, and they're looking at drugs in the child that died as well as the perpetrator, finding that marijuana plays a significant role. And so there are many studies now looking at why this would contribute to violence. And so there's many things that can play a role in that, because it does affect your executive functioning. And it also, the withdrawal symptoms play a big role in this, because that is real irritability, anger, anxiety. Just to quickly go over some of the other problems, cannabis hyperemesis syndrome is something that is a dramatic problem related to high potency THC, and it's just increasing everywhere. It's been flooding emergency rooms in Colorado. This is this idiosyncratic reaction to marijuana. It's not supposed to happen. It's supposed to help with nausea and vomiting, but we're finding with the higher potency products getting people addicted and using more regularly, they're more likely to develop this problem. And so we see this in Colorado, but there's been this huge increase in people showing up in emergency rooms with this. And this is a study just showing that most people that have this also have cannabis use disorder. So they are using this addictively. Then we have not solved the opiate problem with marijuana at all. We have definitely proven that in Colorado, because we have had it available since 2000. So medical started in 2000. This is the overdose rates for all of these drugs. We basically commercialized it in 2009 when the Obama administration said that they wouldn't prosecute anybody in a state that had a medical marijuana law as long as they were following the law. So in 2009, we had 5,000 people on the registry. By 2011, we had 119,000 people on the registry. So we had a sudden increase in all these people that had medical problems. 2010 is when the concentrates hit the market. We legalized recreational in 2012, and 2014 is when the doors opened, and that's when these overdose rates took off. And so there is much research out there showing that one of the biggest risk factors for developing opiate use disorder is using marijuana before the age of 18. And it definitely is not the solution to the opiate epidemic. The industry likes to quote this first article that came out in 2014 that really only covered 1999 to 2010. So that's basically before we got concentrates or high potency products. And this is showing that there was a reduce in the deaths of people who are using medical marijuana. So they basically said this is proof that you can reverse opiate epidemic. They don't like to quote this next article, which came out later. They did the exact same study, but they expanded it through 2017. So they included all the new states that now had medical marijuana laws, and they found the exact opposite. So a total reversal and a 23% increase in opiate overdose deaths. And this is something I think we really need to pay attention to. This is looking at people with opiate use disorder who are on some kind of substitute like MAT, like buprenorphine or methadone. And then they are looking at their use of cannabis, and they found that cannabis use, regardless of the frequency of use, is associated with a 40% increase in the odds of endorsing suicidal ideation. And so we have seen many people dying of overdoses of fentanyl. We never know if those are accidental or intentional, but with this kind of information, I think it's really important that we pay attention to that. And so basically what we can do about this is we have to educate people. That's why I do these talks. And then we have to advocate for, I think, a potency cap. That is something the industry fights tooth and nail. We need increased treatment availability, and definitely it should have treatment in jails, prisons. We need public service announcements about the risks. We need stricter regulations, and people need to collect the data. You need to be asking people. It's not so much about whether you're using marijuana or not. We need to know what kind of marijuana they're using, the route, the frequency, the potency, when did they start using it? And I think people have to do drug screens to help identifying whether somebody is using this or not, so that we can do research. I'd say don't opt for the Colorado panel. There actually is a panel that a drug testing company calls the Colorado panel, because they say that it tests for all the drugs of abuse and all the psych meds without marijuana. And they said that they got that from physicians in Colorado who don't want to know that their patients are using marijuana because they don't know what to do about it. That's really sad. And so we did get this law passed back in 2021, where we were able to put some controls on the concentrates, not very many, but we were able to definitely reduce the amount that people could get. They still can get a whopping amount of THC. Okay, so I will stop at this point, and I'm happy to take any questions or comments or anything like that.
Oh my gosh. Amazing. That was so much great information. Thank goodness we've recorded this. So there is one question in the chat. Can you comment on the growing popularity of ketamine clinics in the context of the negative impact of cannabis? And by the way, Dr. Sarhan has graciously yielded a bit of his time to cover any questions that folks want to follow up with. So go ahead.
Okay. Yeah, ketamine clinics are expanding dramatically. And this is going to also be an issue with all of the other psychedelic hallucinogenic drugs. There may be a benefit of ketamine, but not that I have seen so far in the research. And the problem is these clinics are popping up everywhere. And similar to, I think, the problems that we're going to see with psilocybin, MDMA, the research for these are showing that you need to be present with the person. So you're helping the person work through whatever it is they're working through in their trip or whatever they're experiencing. But what I've seen with the ketamine is people are just passing it out and people are using it at home. And they're not using it in a controlled environment or with a therapist. And I have treated many people who ketamine was their drug of choice. What was interesting, most of them were veterinarians because that is a veterinarian drug. And so it is definitely abusable. People do have problems with it. And I haven't seen the research that is showing this massive benefit. And so this is very similar to NMDA, which the FDA just basically voted against approving because of the studies that were done. The studies are not very well done. And like, I do believe things like ibogaine or ayahuasca or, even psilocybin have potential benefits, definitely. But most all of them, the benefits are with research where somebody is with them the entire time. Like, for psilocybin, it's supposed to be 2 therapists for 8 hours in the room the entire time. Because these are not benign drugs. And I have actually an experience with many patients who were using these hallucinogens to their detriment, even to death. So I have had cases where people have died because of using the hallucinogens. So, even though, that's one thing like people like to say about cannabis. Well, cannabis never killed anybody. We're seeing that differently now in the fact that, especially like cannabis hyperemesis syndrome, that is actually killing people. And because if you vomit enough to deplete all of your electrolytes, you can actually kill your kidneys and you can die. And so there are even young people dying of that. And I attribute that directly to cannabis.
So a comment. Thank you for an amazing talk. There was a recent New England Journal of Medicine article that stated that withdrawal symptoms are generally mild. How would you respond, and what are your thoughts on withdrawal and suicide?
Okay, thanks for that question. Yeah, I saw that article. I went, oh, well, really? Who are you talking about? See, this is the problem with most of the studies. They're not identifying the dose or the product people are using. So I would agree if somebody's using low potency THC, I mean, I'm not sure the plant actually exists anymore, but if they're using small quantities, like they're doing drops under their tongue or pills where they're using 5 milligrams of THC, yeah, probably the withdrawal is mild if they're actually using it daily and then they stop. However, I have not seen that with people with dabbing. So if they're dabbing wax, shatter, these things are 70 to 90% THC, or the edibles. I mean, I worked with somebody who was eating 450 milligrams of edibles every night. That's a whopping dose of THC with very significant withdrawal. I mean, not sleeping at all, not able to eat, and really irritable, very anxious, and I don't think that's mild because it causes people to have to keep using, and that's the whole thing. That's why nicotine is like the most addictive drug, because it's the only drug, at least till now, you use all day long every day. And so the minute you start having withdrawal symptoms after an hour of smoking, you smoke again to make the withdrawal symptoms go away. And that's exactly what I'm seeing with the high potency THC. So I've worked with several young people who are dabbing 30 times a day. Now, they are not dabbing 30 times a day to get high. They're dabbing that often to stop the withdrawal.
Right. And are you seeing a lot of co-occurrence with nicotine, and that because the vaping has changed so much so that they're mixing the e-juice that has nicotine in it with the THC, and then that just creates this And
Yep, that's a very significant problem because you can put anything in a vape, and yeah, people are definitely combining nicotine and marijuana.
right. Thank you. Do we have any other questions for Dr. Stuyt at this moment? And I believe you'll be with us so that we get to the end and you want to chime in on anything. Great. All right. Well, then we will go ahead over to Dr. Sarhan now. And I will tell you a little bit about Dr. Sarhan. Dr. Mohammad Sarhan completed internship, residency, and chief residency in internal medicine at the University of Pennsylvania. He served as lead hospitalist at Jefferson Health in Philadelphia, Pennsylvania. He oversaw nocturnal hospitalists, advanced practice providers, and residents on night medicine rotations and optimizes nocturnal activities to enhance daytime performance. Prior to this, he was an academic hospitalist at Jefferson Health. While at Jefferson, Dr. Sarhan took an interest in resident education in addiction medicine and continues to provide scheduled lectures on addiction as part of house staff didactic sessions. Dr. Sarhan is currently an addiction medicine fellow at Caron Treatment Centers in Warnersville, Pennsylvania, is the primary physician for the young adult male and men's relapse units there. He's got some actual human stories to share, and I know Dr. Stuyt shared a few, but I'm really looking forward to hearing from you, Dr. Sarhan.
Thank you. Let me just get this pulled up here. So good morning. Thank you, Dr. Stuyt, for that wonderful lecture. I am not a huge researcher, but I do have quite a bit of clinical experience from this just 1 year at Caron with the young adult population. And I can very clearly say that everything that you presented is very consistent with what we've been seeing in the young adult population. And also, interestingly, taking care of the men's relapse unit, I can also talk about anecdotally how cannabis has been a major gateway for people returning to use after they've stopped using other substances and have been in long-term recovery. So a little bit about me. I have no disclosures other than the fact that I work for Caron Treatment Centers. I'm a person in long-term recovery also, so I have a lot of experience in the community around substance use disorders, and I was also an alumni of Caron from about a decade ago. I'm board certified in internal medicine and lifestyle medicine. I'm currently a fellow in Pennsylvania. And I'll be moving down to Florida at the end of the fellowship to take over one of the lines of service down there. For now, I take care of the young adult program and we'll be expanding to include teen male services starting on July 1st. So now the young adult program covers patients who are between ages 18 and 25. And then I also take care of the men's relapse program. And these are patients who have returned to use after a period of sobriety where they actively worked a recovery program. And so this presentation is going to be a little bit of a different scope. I know that there's a wide range of experiences and people from the community on this video. So I just was going to focus on destigmatizing language around substance use disorder to help effectively approach people in the community to understand the definitions of addiction, diagnose a substance use disorder, and kind of piggyback on the intoxication and withdrawal syndromes, and referring patients to treatment using ASAM criteria. And at the end, we'll be going through some of the cases that I've seen this year that really kind of go in line with a lot of the evidence that Dr. Stuyt just presented. And so as far as destigmatizing language goes, the Recovery Research Institute asked 35 questions about people actively using drugs and alcohol, and no other information was given about these individuals. Group 1, they referred to the person as a substance abuser, and Group 2, they referred to the person as a person having a substance use disorder. And it was found that the substance abuser was less likely to benefit from treatment, would do better with punishment, was more likely to be threatening, more likely to be blamed for all of the consequences related to their ongoing use, and less likely that their problem was a result of, at least in part, an innate dysfunction over which they had no control. And most shockingly, that they're able to control their substance use without help. And then The National Institute on Drug Abuse, NIDA, has kind of put out a nice little community document that gives you some different words to use. So instead of calling someone an addict or a user or an abuser, to refer to them as a patient, client, or a person with a use disorder. And then instead of using the term abuse, we use use or misuse if it's a prescribed medication. Avoid stigmatizing words like clean and dirty. And the term relapse is kind of moving in favor of return to use. And so that's one of the things that I'm working on at Caron, is to try and change the name of the men's relapse unit, because we have a phase 1 program. We used to have a phase 2 program when we had an extended care model before insurance was accepted. And so I'm advocating to have the men's relapse unit changed to men's phase 2. The American Society of Addiction Medicine defines addiction as a treatable chronic medical illness that involves complex interactions among brain circuits, genetics, the environment, and an individual's life experiences. And people with substance use disorders engage in behaviors that become compulsive and often continue despite harmful consequences. And prevention efforts and treatment approaches for addiction are generally as successful as those for other chronic diseases. The DSM-5 has 11 criteria to define substance use disorders, and these are the same for the most part across all substances. And depending on how many criteria you meet, we grade you between mild, moderate, and severe. And this is these criteria are to be met over the past year. So mild would be 2 to 3 symptoms, moderate is 4 to 5, and severe is 6+. And these are kind of the definitions. They're not in this order on the DSM, but there's a physiologic tolerance and withdrawal paired with craving and compulsions on number 6. And then there's an exhibit of loss of control and continued use despite negative circumstances. I would imagine that most people here are pretty familiar with the diagnosis. And so why is this topic important? In the young adult population, in 2022, marijuana was the most commonly used drug, both illicit and I guess in states where it's not considered illicit anymore, it was still the most commonly used drug. And for the sake of the young adult population, they fit into the top 3 groups. The number 1 group was age 18 to 25, 38.2% of people have used cannabis, and then ages 12 to 17, 11.5%. Group number 2 is the next age group up from 26 to 32. Marijuana use in the young adult population is at its highest level since 1988. Past year marijuana use was 41% in 2021 versus 29% in 2011. And that's, around the same time that the concentrates were developed. Past month, marijuana use 29% versus 17% in 2011. Past day, marijuana use 11% versus 6%. And then marijuana vaping, these years are different because people weren't really vaping in 2011, but 12% versus 6% in 2017. And so for patient approach, keeping with the Hippocratic Oath, first do no harm. We deliver trauma-informed care. We expect that people have been historically treated poorly in medical settings. And, this is a little bit of an extraction from the slides that I give to the residents at Jefferson, but people have also been treated poorly in community settings. And so we also have to meet people where they are and not assume that they're ready to stop. Recognize that the substance may play a role in their survival. And then the usual ask open-ended questions, avoid stigmatizing language, and that this starts from the very beginning. I have the privilege of spending 28 days with my patients, so we spend a lot of time getting to know each other. Some people come in and they've been using opiates and they also use cannabis. And so they're very clear that they want to stop using opiates and they're not so sure about the cannabis. And so we do try and deliver an abstinence-based program, but despite that, we still try and meet people where they are. Unmanaged treatment of withdrawal or unmanaged connections with your patients can lead to AMA discharges, and that very frequently comes with high morbidity and mortality results. And we treat the patients, not ourselves, and I check in very frequently with these people. This is a list of reasons of using, and some of them are a little bit more problematic than others. And so this is for people who are using by age 19 and 20. And so the most frequent use pieces are to feel good or get high, have fun with my friends, experiment. And then it starts to get a little bit more tricky. And these are some of the underlying aspects of cannabis use disorders that we try to treat in a comprehensive care setting. So to relax or to relieve tension. So to figure out what it is that's causing the tension because of boredom and nothing else to do. So a lot of patients are failure to launch patients and require very long extended care programs and need help with redirection and a lot of the stalling that happens from cannabis use in adolescence. To get away from my problems and troubles, to seek deeper insights and understanding because of anger and frustration. So this is quite subjective, but this is a lot of the stuff that we focus on while patients are with us. For those in the community, and if you see patients, there's a cannabis use disorder screening tool, and it is designed for self-administration. I have it on the next couple of slides, but a score greater than 8 indicates hazardous use, and a score greater than 12 indicates possible cannabis use disorder. These are the items. It relates to how much you use, how often do you get high, how often in the past 6 months have you not been able to stop, how often did you fail to meet obligations? How much time do you spend using, trying to obtain the cannabis or recovering from it? So these are pretty consistent with some of the DSM-5 criteria, and memory and concentration problems, and how often do you put yourself in dangerous situations, and have you thought about stopping or cutting back? The acute intoxication is consistent of euphoria, perceptual alterations, time and spatial distortions, intensification of ordinary sensory experiences, and motor impairment. These are some of the synthetic cannabinoid medical complications that are often seen in hospital settings. So these are not harmless when used in very large amounts, as people with cannabis use disorders tend to do. Multisystemic impact. Dr. Stuyt already covered some of the withdrawal symptoms, but they typically begin 24 to 48 hours after cessation. But really, as we talked about, people are taking huge dabs multiple times a day, and it is to keep withdrawal symptoms at bay. The withdrawal symptoms tend to peak at days 2 to 6, and we have a pretty we have a good deal of difficulty trying to manage withdrawal symptoms from cannabis and trying to get people to stay in treatment. And then after the acute withdrawal phase is over, the post-acute withdrawal symptoms can last months or years. And as Dr. Stuyt mentioned, the withdrawal symptoms are basically the exact opposite of the intoxication symptoms. Cannabis withdrawal, irritability, anger, or aggression, nervousness or anxiety, sleep difficulties, and this is really hugely problematic when we have patients in the acute inpatient setting. Decreased appetite or weight loss, restlessness, and depression. Some, especially with the higher potency users, we have abdominal pain, tremors, sweating, fevers, chills, and headaches. They really tend to get systemically unwell. These are some withdrawal checklists that can be used, the marijuana withdrawal checklist and the cannabis withdrawal checklist. Neither of them really offer a ton of guidance on management, as most of the care is supportive. Withdrawal management is almost 100% supportive. The biggest trick to this, I found, is trying to manage patient expectations. We have really great difficulties with people and sleep and anxiety, requesting other substances to treat basically the symptoms that they were using the cannabis for, Ambien, Xanax, Klonopin. And so the goal of what we try and do is place attention on the clinical side, which is the therapy, psychology, neurobiofeedback, to try and encourage these patients to stay away from medicating these symptoms as they resolve. There are currently no medications approved. There are trials, as Dr. Stuyt mentioned, for durabinol, nabiximols, and gabapentin. However, it's really not something that has much clinical application for us at Inpatient Treatment Center at this time. Post-acute withdrawal syndrome is consistent of fatigue, mental fog, inattention, urges and cravings, depression and anxiety, stress sensitivity, same as the withdrawal symptoms, but just kind of a little bit more attenuated and longer lasting. This is kind of where the bulk of what I want to talk about is. So I really have strong connections with my patients, and this is the first one that I thought of. It's kind of a shocking story. He's 18 years old, and ever since he was a child, he was diagnosed with all sorts of various behavioral abnormalities and diagnoses, most recently intermittent explosive disorder. He'd been in treatment basically all through his childhood for his behavioral problems, and he began to use cannabis at around age 12. He started to do a little bit better at home. And so a family therapist suggested that the parents allow it. And so they did. And he did better for some time. And then he started to experience significant rebound anxiety. And he was prescribed Klonopin. And he started to misuse the Klonopin himself. And so the parents started to lock the Klonopin in a safe. And they would come home from work and the safe would be crowbarred open, and they would upgrade to a higher grade safe, and he would still get into it, and then it would upgrade into a higher grade safe. And ultimately, he overdosed while he was at school, and he was given naloxone reversal. And after the overdose, he got expelled from school, and so his parents were seeking treatment. When he got to us, his labs were within normal limits, so there was really nothing biochemically wrong with him. The urine drug screen was positive for THCs, benzodiazepines, and fentanyl. He himself took a lot of shock to the fact that there was fentanyl in his urine, and I think it served as a big motivator for him to stay in treatment because it scared him. But he really had a tough course with us. He had rebound anxiety, rebound insomnia, very restless, inability to engage with treatment, was agitated. We have counselor assistants that basically spend all of their time with the patients on the units, and he was getting, report after report after report around behavioral problems, and he was quite agitated and very irritable with us. And so this is kind of what we did for him. We focused on supportive care for his withdrawal symptoms. He was on a prolonged Librium taper to help come off of the clonazepam. He was given a variety of what we use as comfort medications, that propranolol for anxiety, hydroxyzine for anxiety, clonidine. We did what we could to kind of keep him as low as possible. And I think most impactfully, he had a psychiatric evaluation, and he wasn't very forthcoming with us during his psychiatric evaluation. So I took it upon myself to get some pretty heavy collateral history from his family. And it turns out that the father behaved very similarly when he was growing up, and he had a very late generalized anxiety disorder and panic disorder diagnosis given to him. And he was started on Zoloft and up titrated to the max dose of Zoloft. And everything got better in his life. So that kind of gave us a big insight into what might work for this patient. He was engaged in trauma programming. We had his parents come up several times to engage in family programming. He was working on his sleep hygiene. And we started to up-titrate his Zoloft. And by the end of the 28 days, I think he was at 100 milligrams. And he was very, very, very functional compared to when he first came in. He went to an extended care program, one of our programs in Florida. And he stayed there for 90 days, and he's currently back in school, about to graduate, and has gotten himself into college. And the only medication that he's currently on is Zoloft. So it took some time. It took a lot of people. He had neurobiofeedback services to help with anxiety symptoms. But we were able to kind of turn this case around. One of the things that I really wanted to mention around this patient is that we have a lot of people who come through who have opioids laced into the cannabis that they're using. There was a patient who wasn't on the young adult program, but he was on the men's relapse unit, who came in for a primary cannabis use disorder problem. And when he was transferred to his primary unit, he went into overt opioid withdrawal. And anecdotally, we really had no idea what was going on until his drug screen came back, because we have send out fentanyl screening, and found out that his fentanyl was above the upper limit of what's detectable on the urine screens. And so he ended up going on Suboxone to manage that. So it is kind of a huge problem, and it definitely exists. Case number 2 is patient B. He's 21. He's a triplet. And neither of his siblings have any medical or psychiatric diagnoses. He had graduated from college and was working at an art gallery in New York, and was visiting his aunt when he locked himself in a room and started to destroy the space around him. And when we asked him about it, he would tell us about this invasive force. He was admitted to psychiatry and started on a mood stabilizer, transferred to a different treatment center, and he attempted suicide while he was there. He was admitted to psychiatry again, started on an antipsychotic medication, and was transferred to us. And on arrival, he was completely extrapyramidal. He was muscle rigidity, flat affect, and really was going to have a hard time to engage with treatment. So with this patient, the first line of treatment for us was to get him a psychiatry consult. We did not know whether or not he was going to be able to engage based on the way that he had arrived to us. And he was on a long-acting injectable antipsychotic. And so he was given some medications, namely Cogentin, to help with the extrapyramidal symptoms. He cleared up a little bit, and he was ultimately able to engage with treatment. After spending a lot of time with his family with psychiatry, we were able to determine that he probably did not have a bipolar disorder. He probably did not have schizophrenia. He was using extremely high dose, high potency THC by dabbing, and that he likely just had an extreme psychosis related to his cannabis use, and that we could probably stop all of his medications. And so his medications were stopped entirely. And 28 days later, he was back on his feet, going to the gym, doing his thing, enrolled in extended care, and is still currently doing really well, back working at his art gallery in New York. I apologize, but I think I'm zipping through these pretty quickly. And we have a couple more cases, but hopefully we'll leave some room for discussion afterward. Patient C, he's 20 years old. He had just graduated from a University in Chicago. And he didn't really ever have any signs or symptoms of any sort of substance use disorder. Throughout high school and college, he drank in a manner consistent with his peers. When he graduated from college, he felt that he was having difficulty coping with working, with living on his own, with keeping up with everything. And so he was seen and given a medical card for anxiety. And so his use rapidly escalated, and he became hyper-religious, grandiose, and began to preach to his loved ones, to his family and friends. And he has a family history of bipolar disorder. His mother is bipolar, and one of his siblings is bipolar. So his family knew exactly what was going on. They lived in New York and had him admitted to a psychiatric hospital in Chicago. And so he was started on a mood stabilizer, and he basically what was presumed was that his underlying psychiatric diagnosis of bipolar may or may not have ever emerged, but definitely was precipitated by his high potency cannabis use. And so he was managed for bipolar disorder, started on a mood stabilizer, and he's also doing well. The next case is patient D. He's 45. He's from the men's relapse unit. And he first sought treatment for cannabis use disorder at age 18. And which is kind of strange given the time frame, but he was in stable recovery for 25 years. He actively worked a program, did not use any other substances in the meantime, and sustained an injury and was given a prescription for oxycodone. And very shortly after, he was using illicit opioids, and within a few months had escalated to, he was admitted to the hospital for an overdose and transferred to us for treatment of both severe and cannabis use, opioid and cannabis use disorders. And there's pretty strong, I think Dr. Stuyt presented some of it, evidence around the use of opioids after the use of cannabis use during adolescence. And this is a very, very demonstrated case of that. He's had plenty of experience with being in recovery. He, high functioning individual who understood kind of what was going on and had practiced a great deal of acceptance. And he did fine, I think, mostly based on his years in recovery. But this was just I just wanted to bring this in as an example of people using opioids later having used cannabis in their adolescence. Referring patients to treatment can be complicated. We all know that substance use disorder, there is as many ways to be in recovery as there are people in recovery. And referring people to treatment can be complicated. So the acute care model of treatment is kind of on its way out. We're looking at addiction as a chronic illness. So before, people would go to treatment, they'd receive their treatment, they'd leave, and we'd say, see you later. Now, I think with the advent of the field of addiction medicine, the goal overall of the specialty is to reduce the morbidity and mortality associated with this disease, to maximize people's function and to improve their wellness. And so the chronic care model involves prevention, early identification using screening tools, referring people to treatment, and then recovery supports afterwards. And so I typically don't include this when I talk to when I give talks, but I wanted to include this because of the fact that this is a Montgomery County-based organization and that we can be a very strong local resource for people. And so the ASAM criteria, there's 6 ASAM criteria. They recently changed. There's a textbook on it that kind of details the exact aspects of each one of these 6 dimensions. The first is the intoxication, withdrawal, and addiction medicine. The second are co-occurring biomedical conditions. The third are psychiatric and cognitive conditions, and dimensions 4, 5, and 6 have to do with the therapy side, but substance use related risks, recovery, environment interactions, and patient-centered considerations. And we use these 6 dimensions to determine levels of care for our patients. Level 4 is a medically managed inpatient. We don't offer that at Caron, but this is for people who require hospitalization for management of medical issues related to their substance use, whether it's a medical diagnosis or whether it's hospital level withdrawal management care. And then level 3 is residential. Level 2 would be the intensive outpatient and partial hospitalization programs, outpatient services, and then recovery maintenance. And so we offer medically managed residential, which is 3.7 and below. We have our main campus in Wernersville, Pennsylvania. It's about 70 miles outside of Philadelphia. We have outpatient services in Wyomissing and Plymouth Meeting, some alumni services in New York and Washington, and outpatient services in Atlanta, and then inpatient services in Florida also. This is what our little campus looks like in Wernersville. There's a road there that divides the campus in half. This is the south half, and then there's another north half. It's like a small liberal arts college. It's a very lovely place to go to treatment. And these are the services that we offer, the service lines. We have a female and male continuum. They both currently include a young adult primary unit and a relapse unit. The teen services are opening on July 1st. We have an older adult program and a Grandview program. These are considered our signature services, and unfortunately do not have an insurance component attached to them yet. We have a Renaissance program, which is an extended care model for failure to launch and people who require 3+ months of aftercare at a high level of aftercare after they discharge from our services or referred from other programs. We have a partial hospitalization program for both substance use and mental health, a healthcare professionals program, legal professionals program, and then intensive outpatient services. The Breakthrough program is a 5-day intensive. It's an experiential program that's offered to people who have at least 1 year of recovery and anyone who's looking to improve interpersonal relations. And then recovery informed coaching. We have medical stabilization services and offer medications for treatment of substance use disorders, psychological and psychiatric treatment and assessment, neurofeedback therapy, and neurorestorative services, which is one of the aspects of what we offer that's currently growing. Addiction interaction disorders, these have to be secondary, they cannot be a primary. Specialty tracks for chronic pain, trauma, relationships, parenting, pride programming, spiritual services, lifestyle services. Dr. Stuyt, all of our patients go to the gym every day. And sleep hygiene, exposure to support groups, whether they're on campus and off campus. That includes AA, NA, Smart Recovery, Dharma Recovery, family education and therapy that's offered to every single patient. And if the family circumstances aren't such that the family can attend while the patient is there, those services are offered at any time. So families could join a year after their loved one was discharged if that is better suited for them. Aftercare services, and we have a pretty robust research center with clinical trials. And so that's kind of what we have to offer the community. I am happy to take any questions about any cases or if anyone has any comments for discussion.
Just in line with some of those case studies, the one question that I have while we're waiting for others to bring up their own is, do you see a return to use for when THC is the primary substance that's more frequent or less frequent than other substances? Or are you aware, either of you, if you know any of the data on that?
I can anecdotally say that it's a yes, particularly in the young adult population. There is still very much there's very much a thought that cannabis is not harmful. And even though some of our patients who come in, they have a lot of consequences related to their substance use, they may not have developed psychosis, or they may not have developed cannabinoid hyperemesis syndrome, or they may not be in an environment where violence is a problem. And so the psychosocial consequences, I guess, aren't seen as significantly. And so typically our young adult population does very, very well, particularly because we have a pretty good extended care program for them. But I can say that I have seen 5 people come back for treatment that I had treated this year. So in this 1 year, 5 people have readmitted. And of the 5 people, 4 of them were for cannabis use disorder. 1 of them was for opiate use disorder. And so, you know, I don't have years and years of experience. I'm sure Dr. Stuyt has something to say about this, but I can say that anecdotally, yes, we do see people come back a lot.
In my experience, I have yet to ever meet somebody who goes to treatment without a consequence. It is consequences that motivate treatment. I mean, that's really why I have focused so much on tobacco my entire career, because most of the drugs are pretty forgiving in terms of a consequence. Like if you have a legal consequence or a family consequence, or even the psychosis can be temporary if you stop using. However, most people wait for a consequence for tobacco, and then it's too late. You've had your heart attack, your COPD, your lung cancer, and I mean, yeah, you can quit, but you haven't avoided the consequence. And so that's why I think it's imperative that treatment programs provide an environment where people are able to quit smoking, and encourage that. And I really do think that that improves outcomes, and it really does help. And I've helped a lot of treatment programs go tobacco free, but most of them are very concerned they're going to lose business, that people aren't going to come to them because they can't smoke. And that is totally not true. Totally not true. But anyway, I think that, you know, that's part of what Oregon experienced. You know, Oregon decriminalized everything, and then they are offering treatment, but there's no incentive for people to get treatment. And so people are not getting treatment, and they've had horrible problems. And that's why they've reversed, and now they've recriminalized. So, you know, that's at least what I think.
There are just no simple answers to this, are there? It's just so complex. That kind of in line with that, there was a question asking about the reasons the patients with cannabis use disorders come into treatment. Do you have any data on the reasons they're seeking treatment? As you mentioned, some of those consequences, but also if there's any correlation to the outcome based on the reason that brought them into treatment.
I don't have data. Unfortunately, that hasn't been one of the, I'm sorry, am I back on this?
No, you're okay.
I don't have data, but I would say that for the young adult population that we have, it usually is not the patient who is the most enthusiastic about seeking treatment. It's usually the family. And we don't take people who, everyone has to sign in voluntarily. And what voluntarily means to each patient can be very different. Some people can, you know, they're forced by their family because they are going to get kicked out or are going to be cut off, or for a variety of other reasons. And then there are some people who show up voluntarily knowing that they need help. The latter population is not what I see on the young adult population. But I would say that people who have unresolved or have heavy trauma diagnoses tend to be a big return to use population. Unresolved mental health needs in general, a huge return to use population. But outside of that, I would say that there isn't probably a ton of specific consequences that bring people back to treatment.
Thank you. And since we're on that, Dr. Stuyt, I've heard you give a really beautiful explanation of motivation and what drives motivation to recover. And you talked about, I've heard you talk about how somebody with alcohol use disorder, because of the solubility of those fat cells, with alcohol goes through the system more quickly. And you talk of, can you just, I'm not going to use your words. Can you describe that, how you explain how cannabis is so challenging with that motivation to abstain?
Yeah, well, I mean, alcohol is water soluble and it's metabolized very rapidly. So when somebody has an acute problem with alcohol, it really gets people's attention. But then they can recover. I'm amazed. To me, alcohol is the most forgiving drug because, like most of these drugs, do impair sleep because people use them to sleep, and then when they can't get them, they're not sleeping. But alcohol seems to normalize sleep architecture within 30 days of quitting. And so, that's why I think 28-day treatment models can work well for alcohol use disorder. And it leaves the body. And if you haven't, got wet brain from drinking way too much, then it can actually, you can recover pretty well. The cannabis, on the other hand, this fat soluble substance, it sits in your body for a very long time. And it also depends on how heavy you've been using, how often you're using, and it really varies from person to person. And so in my treatment program, I was having people still having positive urines, like THC metabolites in their urine, 6 weeks out. And so they're still having this protracted withdrawal thing that really encourages the use. I mean, if you're feeling miserable all the time and the solution is to just use, you're gonna use. And speaking to this opiate and cannabis connection, there is a lot of research showing that these receptors are integrally related in the brain. And in my experience working with people with heroin, for example, I had many, many people that it was heroin or opiate use disorder that they were in treatment for. And they would tell me that they were really unhappy that they lived in Colorado. And I said, well, why is that? They said, well, there's a dispensary on every corner. And if I go back to smoking marijuana, I guarantee you I will be using heroin. And so they know this themselves. I mean, this isn't, research telling them this. They just know this experientially. And so that's why to me, it's such a problematic drug because it affects the system that we have in our brain that we're supposed to have. It's our own natural system. But the cannabis then hijacks it, really messes it up. And so we're not able to do what we really need to be doing. I'm not sure that helped that answer.
Yeah, no, that's great. And it impairs learning. And you said how important learning is to recovery, right?
Yes. Yeah. And to me, that's all of what this is about. I mean, we have a really good understanding of the neurobiology of how all these drugs work and how they work in the brain and how it does affect your learning and memory system and how it hijacks that. And so to me, the solutions are you have to stop putting that drug in your system, but then you have to learn skills. And that's why treatment is so important and incorporating all of these different skills. And one thing I didn't hear Dr. Sarhan talk about, but I encourage you to look into if you don't use it, is this ear acupuncture protocol that I have used since 2000 in my treatment program. And I was finding it actually helpful for cannabis, which was kind of amazing to me because I started seeing people definitely with cannabis hyperemesis syndrome. So they're in treatment and they're vomiting and, they're not happy. And just that treatment really helped calm that down. And I think maybe part of that is because one of the needles, one of the points is for the GI system. And I also found it really helpful for psychosis. People with psychosis are the least likely to be willing to let people put needles in their ears because they think you're putting something in their body. But once they're encouraged to try it, and they do try it, I found people, especially my most delusional patients that had really very fixed delusions. And I had quite a few like young men with this delusion that the CIA had implanted electrodes in their brain and were monitoring them. And so one of them would come to that AccuDetox treatment. We offered it 5 days a week, and he came every time. And I said, "Does this really help you?" And he goes, "Oh yeah, it makes the voices really go away." And so whether that is totally placebo, who cares? Who cares really? Because there's no downside to this treatment. And so it's a way of teaching people how to begin the stress management. And I found it a way to help people calm down enough so that they can actually participate in the rest of the program and learn all the skills that we're trying to teach people.
Amazing.
We do use acupuncture and we find it to be very, very beneficial. There's also two devices. One of them is called the Bridge device and the other is called the Sparrow Ascent device. And the Bridge device, the Sparrow Ascent is like a sticker that goes around the paraauricular area and attaches to a self-controlled machine where the patients can control the electrical impulse that goes through the sticker. And then the Bridge device is a little bit more invasive, but it has these tiny, tiny little needles, and it goes into 4 different spots around the ear, also connected to a device that puts in electrical impulses. But they're really only certified for opioid use disorder, so that's really the only population that we've been using the devices on for treatment. But I'll bring it up to maybe consider it for people with cannabis use disorder also.
Yeah, well, and I mean, the needles you can use on anybody.
Yeah, the needles are for, yeah.
Yeah.
Great. Here's a question. Should a primary care physician be concerned about using an ICD-10 substance use disorder diagnosis? Will it impede military service eligibility or other consequences?
That's a good question, especially the young adults. Oftentimes they're looking for that. There is I'll put it in the chat, but there is a document that kind of lists, I have it here on my phone, about the military standards on drug and alcohol use. I'll give you an example. Like if for drug trafficking, there's no possible waiver for any branch of the military. For drug and alcohol use, the Navy will allow it if you've demonstrated a program of recovery, whereas the Army, Air Force, and the Marines will not. So it depends on the branch, but some of them have waivers and others do not.
And anecdotally, I know that having a history of substance use disorder impacts your ability to get life insurance, because I went through that like a couple years ago. So until you're out of treatment or in recovery for 10 years and out of treatment for 10 years, you have to go through like a full medical evaluation to get life insurance. That was something that I went through a couple of years ago, but now I don't have to worry about that because I've been in recovery for longer than 10 years.
I didn't know that. That's so interesting. Wow. Thanks for sharing that, Bob. Don't see any. One more question that I have is, Dr. Stuyt, you talked a lot about psychosis, the cannabis-induced psychosis. Can you say a little bit more about rebounding from that and what the outcomes are looking like? I know that we hear some pretty unpleasant outcomes. You mentioned some cases that you have seen some, and so has Dr. Sarhan, but others where it does seem to be more permanently impactful. Do you see anything in the treatment protocols that influence some of those outcomes, one way or the other?
But I can speak to that. Yeah, I've worked with many, many people with cannabis-induced psychosis, and majority of them have recovered from the psychosis. However, then they don't go back to using marijuana. And that's the most important key. And I have seen several people who have not recovered and that now have full-blown problems. like an example, a young man I was working with who he basically was dabbing and multiple times a day, and he became extremely psychotic and then attempted to strangle his mother, which was totally out of character for him. And he ended up in a psych hospital, and very similar to one of Dr. Sarhan's stories, he was put on, actually it took 3 antipsychotics to stabilize him. And so one of them was Depot. He was on Depot Haldol, so an injectable form. And it took 2 months in the hospital to stabilize him. Then he gets stable, he's normal. And I then picked him up in treatment, and I was supposed to follow his medications. And so I got the history that they did not get in the psych hospital because they didn't ask the questions and they didn't do the urine drug screen. Well, no, they did do I take that back. They did the urine drug screen and they could not believe his symptoms were based just on THC because that's the only thing that was in his urine. And so they thought they had missed something, that they didn't test for or something like that. But then I got the history he was dabbing. They didn't get that history. Most people are just asking, do you use marijuana? Yes or no? Yes or no? Okay. He was dabbing. And so when I saw him, he had the worst case of akathisia I have ever seen. He could not sit still. He was up and down, up and down, up and down. And that was because of the antipsychotics. And it was clear he was not going to take them. And he really wanted off of them. And because he was no longer psychotic, I agreed to work with him. And so over a period of time, we slowly tapered him off of all 3 of them. And he was doing really well. He did great. And I told him to stay away from marijuana. Please don't ever go back to it. Well, it was like a month later, his family brings him back and he's psychotic again. And I said, what are you doing? And he goes, I started dabbing again. And so then he's right back to full-blown psychosis. We had to stabilize him again. And then, of course, then he wants off his medication. But I mean, he now has the negative symptoms of schizophrenia. He did not, we no longer had the positive symptoms, but he had a lot of negative symptoms, and he's not a normal person. And I did work with him to take him off the antipsychotics, but that very sad. So he has a permanent problem now, and that's the case. So people have to stay away from this. They can't be putting it back in their system, or they're going to have the same problems.
Thanks for that.
And then the other place I have the biggest problem is convincing people with cannabis hyperemesis syndrome that is causing their problem. They cannot believe that at all. And so it takes a lot of work. I mean, you have to really spend a lot of time with them and really help them understand this. And yeah.
Yes, thank you for that. Yeah, this is so confounding, and we're up against this, the social norms of this being, in the Cheech and Chong era, and we're just so far from that. It's
Right.
really astounding. If you have family members who are struggling with how to navigate this, please send them our way, folks, because we work with family members constantly who are, you alone are trying to do this, and here you have some experts in the field who are saying this is a challenging subject to navigate. So please know that we are here to support you as family members, because this is not easy to see this happen in your loved one. I'm so grateful that my son actually was on that little campus that Dr. Sarhan showed a picture of in 2010, and he's been sober ever since. So his THC did not look anything like, it's not even not your dad's weed. It's not your older brother or sister's weed. So very, very different. And I hope that if any of you who have watched this or been with us this morning hear anyone use the words just weed, send them this recording once it's available, because obviously there's so much more to this than what people in the general public are really understanding, and in the medical profession. So please share this among the professionals as well. Dr. Sarhan, Dr. Stuyt, I cannot thank you both enough. This has been amazing. Thanks to everybody for being with us.
You're welcome.
Wonderful. Have a great day, everybody. And thank you again. This is amazing.
Thanks. Bye.